Bismillahirrahmanirrahim. Today I'm going to present the ovarian cyst in postmenopausal women. How would we manage this case? Before going in detail of this guideline, first of all, we need to discuss this table. This table is very important because it shows us the whole summary of what we will do in a postmenopausal woman if ovarian cyst is diagnosed in them. Okay, so if a postmenopausal woman comes with a cystic lesion of 1 centimeter or more, this is also very important that if the cyst size is less than 1 centimeter, then no need to consider it. But if it is more than 1 centimeter, we need to consider it. Okay, and what we will do, we will check the CA 125 level. Okay, and also we will do TVS plus minus TS in order to calculate the RMI. We will discuss RMI in detail later. Okay, then there are two pathways. Okay, if RMI is less than 200, if RMI is more than 200, what we have to do if RMI is less than 200? If RMI is less than 200, it means that there is a low risk of malignancy. If RMI is more than 200, it means that there is increased risk of malignancy. If RMI is more than 200, then we have to refer the patient to gynecological oncologist, or we have to do CT scan because there is increased risk of malignancy. That is another pathway. But what we have to do when the RMI is less than 200, in that case we can either go towards surgery or conservative management. In what case we have to do the conservative management? Okay, when the cyst fulfills this criteria, like if it is asymptomatic, if it is simple cyst, if it is less than 5 centimeter unilocular unilateral. Okay, so if it fulfills this criteria, then we have to follow the conservative management. How we will do? We will reassess the patient in 4 to 6 months, and we will recheck CA125 transvaginal ultrasound or transabdominal by doing the RMI. And if it resolves, then we discharge the patient. If it is persistent or unchanged, then we have to repeat assessment in another 4 to 6 months. And if it persists further, then individualized treatment after discussion with the woman. But if there is some change in the feature, then we have to consider intervention. So that was about the conservative management. Okay, now what we have to do if the cyst, if the RMI is less than 200, but if the cyst show these features, if the cyst doesn't follow the features of the conservative management, if it is non-simple, if it is more than 5 centimeter, if it is multilocular and bilateral, then we have to consider surgery, salpingo-oophorectomy, usually bilateral. Okay, and if the RMI is more than 200, then what we have to do, we have to do CT scan, abdomen, pelvis, and refer to gynecological oncologist and MDT review. If there is if MDT review, when we in MDT review, we thoroughly see the whole patient in each and every aspect. We see the family history, we look at the other risk factor in her, and we look at the general status of the patient by asking from physiotherapist and whoever is present in the multidisciplinary team. And if we come to know that there is a high risk of ovarian malignancy in this patient, then we have to consider laparotomy with a full staging procedure by trained gynecological oncologist. If the multidisciplinary team proves that although the RMI is more than 200, but there is low risk of ovarian malignancy, then what we have to no need to do laparotomy for full staging procedure, but we have to do, as this postmenopausal woman, so we have to do pelvic clearance, TH plus BSO plus omentectomy, thus peritoneum is cytology by trained gynecologist. Okay, now in the same table RMI calculation is written that in RMI UMC we have to remember this. Okay, U means ultrasound features for what? Okay, if each of these features are present, like multilocular cyst, solar cyst, evidence of metastasis, bilateral lesions, okay, increased blood flow or other things like that, then it means that there is evidence of malignancy, and we have to give score 0 to U if we don't have any of these features. If there is score 1, there is one feature, then score 1. But if we have 2 to 5 feature, more than 2 or more than 2, then score 3 should be given. Means if we have two features, then we have to give score 3. Post menopausal status, if she is pre-menopausal, then score 1. If she is post-menopausal, then score 3. C125 is my in international unit per ml. Okay, so this was the nutshell of the whole guideline. Now we have to discuss the what's written in this guideline. Inside of this guideline, what is written, we have to discuss a little bit. Okay, nothing special is written in purpose and scope, but in the introduction epidemiology, in the first paragraph, what is written, the incidence of ovarian cyst in postmenopausal women is given. That ovarian cyst is common in the postmenopausal women. The exact prevalence is unknown, but the studies have shown that the overall incidence is estimated to be 5 to 17%. Okay, and another paragraph, what is written, that what size of postmenopausal cyst is significant, that is written here. Okay, the greater use of ultrasound in gynecological practice and widespread generalized use of other imaging techniques such as CT and MRI means that an increasing proportion of these cysts will be found incidentally. Okay, although most of the cysts are found incidentally by using the CT and MRI, but if cyst is greater than 1 centimeter, that is very much significant. Okay, and how to improve morbidity outcome? Morbidity outcome is improved by taking these 3 measures: using conservative management where possible, use of laparoscopic technique where appropriate, and referral to gynecological oncologist. Okay, so these things are very important. Now coming toward the point 4, which is very important: how are ovarian cysts diagnosed in postmenopausal women and what initial investigation should be performed? Okay, so the bold letter should be studied. Okay, the clinician should be aware of the different presentation and significance of ovarian cysts in postmenopausal women. Okay, and in the postmenopausal woman presenting with acute abdominal pain, the diagnosis of ovarian cyst accident should be considered, that is torsion, rupture, or the hemorrhage. Okay, and it is considered the ovarian cyst in postmenopausal women should be initially assessed by measuring the serum cancer antigen CA125 level and transvaginal ultrasound scan. Okay, so in order to calculate the RMI, it's very important to check the C125 and also the TBS findings. Okay, and so that is the these are the two important investigations which are done usually. Now in this first paragraph, the main thing which is written is that how do ovarian cysts present in the postmenopausal woman? Ovarian cysts in postmenopausal women could present in 1 or 3 ways. In 3 ways it presents. Okay, okay. So number 1, some women presents with acute pain in the form of torsion or rupturosis. Secondly, other women have ovarian cysts identified during gynecological investigation. For example, if she comes for with a postmenopausal bleeding, or if she comes for other gynecological purpose, and we incidentally find in her. And finally, some ovarian cysts are found incidentally in postmenopausal women undergoing investigation by other specialties for non-gynecological condition. For example, cross-sectional images for general, surgical, and medical indications. Okay, so in first case, in case of emergencies; secondly, in case of gynecological management, or when she is undergoing for gynecological investigation; and thirdly, for non-gynecological investigations. And the same things are written in these paragraphs. No need to study these in detail. And the thing which is very important here is that point 4.2, what is the history and clinical examination, what is the role of history and clinical examination in postmenopausal women with ovarian cysts? This is very much important. Okay, that a thorough medical history should be taken from the woman with a specific attention to the risk factor and symptoms suggestive of malignancy, and family history of ovarian, bowel, and breast cancer, especially ovarian, bowel, and breast cancer, OBP. Okay, ovarian, bowel, and breast cancer, we have to take special history from such women. And where family history is significant, refer to the regional cancer genetics service should be considered. Appropriate tests should be carried out in the postmenopausal woman who has developed symptoms within the last 12 months that suggest irritable bowel syndrome, particularly in women over 50 years of the age, or those with a significant family history of the ovarian, bowel, or the breast cancer. Okay, and a full physical examination of the woman is essential and should include BMI, abdominal examination to detect ascites and characterize any palpable mass, and vaginal examination. Okay, so we have to do general physical examination, we have to do abdominal examination, we have to do vaginal examination. Okay, and we have to assess the proper size of the mass by doing examination if we can do it, and we have to detect whether ascites are present or not. Okay, now some things are very important in this paragraph, that family history should be taken from the patient, because these women are at increased risk of ovarian CA. Okay, and which women are at increased risk of ovarian CA? Those women who are a woman is defined as being at high risk of ovarian CA if she has a first degree relative, mother, father, sister, brother, daughter, or son affected by cancer, okay, within a family with. Okay, now there are five main points, means those women who are at risk. In the first point, women with two or more individuals with ovarian CA. In the second, one with ovarian CA and one with a breast CA under age 50. And third point, one patient with one relative with ovarian CA and two with a breast VA under 60. And in the fourth point, three patients with colon CA, or two with a colon CA and one with a stomach CA. And in the fifth point, one with both breast and ovarian CA. Okay, so if we have patients like this, then these patients are at means if we have first degree relative with these things, then there is increased risk of malignancy. Okay, now coming to the point 4.3, that what blood test should be performed in postmenopausal women with the ovarian CA. As we know that CA-125 should be the only serum tumor markers for the primary evaluation, as it allows RMI calculation period in postmenopausal women to be calculated. And CA-125 level should not be used in isolation to determine if the cyst is malignant. Okay, and while a very high level may assist in bridging diagnosis, a normal level does not exclude the diagnosis. Okay, there are certain conditions in which the normal level means the normal level does not exclude the ovarian CA. Okay, because it's written that a cutoff value of CA-125 is that of 35 international unit, but we have the sensitivity of about 81% and specificity of 75% if the cutoff of 30 is used. Okay, so it's written here, if the cutoff of 30 international units is used, the test has sensitivity 81% and specificity of 75%. Okay, now what are the other conditions which can result in increased CA-125 level? Okay, non-malignant gynecological conditions such as pelvic inflammatory disease, fibroid, acute, even a benign cyst, torsion, rupture, hemorrhage, or endometriosis can all result in increased CA-125 level. And it's also written that numerous benign non-gynecological conditions that can cause peritoneal irritation, like tuberculosis, cirrhosis, ascites, hepatitis, pancreatitis, peritonitis, and pleuritis, and other primary tumors that metastasize to peritoneum can also give rise to elevated CA-125 level. Okay, now what are the other tumor markers? Okay, apart from the CA-125, we may have other tumor markers which needs to be considered, and those include the HE4. HE4 is human epididymal protein, carcinoembryonic antigen, and CDX2, and cancer antigens 72 and 4, cancer antigens 99, alpha fetoprotein, and LDH and beta HCG. These are also important tumor markers, but currently there is not enough evidence to support that the routine clinical use of other tumor markers have role in detecting ovarian malignancy in postmenopausal women. Now, it's very important to study the role of HE4. Okay, HE4 level, the role of it is important, that HE4 is glycoprotein found in epididymal epithelium, and increased serum HE4 level and expression of HE4 gene occurs in ovarian cancer, as well as lung, pancreas, breast, bladder, and ureteral transition cell, and endometrial cancer as well. Okay, and it's written that there was one study Okay, here it is written that a retrospective report of a retrospective report of once found that CHE4 level was had a sensitivity of 73% compared to C125, which has sensitivity of 43%. For 95% specificity in distinguishing between benign and malignant ovarian tumor, and addition of the HE4 and C125 improved sensitivity to 76.4%. Okay. However, it is also written that HE4 is not in routine clinical use, and the data on HE4 are not substantial enough to enable it to be recommended for routine use. Okay, now there is not enough evidence to suggest that the panel, including the multiple tumor markers, offer any further advantage in initial assessment of ovarian cysts in postmenopausal women. Now, what imaging should be employed in assessment of ovarian cysts in postmenopausal women? Okay, what imaging should be what imaging should be applied. A transvaginal ultrasound pelvis is the single most effective way of evaluating ovarian cysts in postmenopausal women, and transabdominal ultrasound should not be used in isolation. It should be used to provide supplementary information or to transvaginal ultrasound, particularly when ovarian cyst is large or beyond the field of view of transvaginal scan. On transvaginal scanning, the morphological description as subjective assessment of ultrasound features should be clearly documented to allow calculation of the risk of malignancy. Now, transvaginal scan should be performed using multi-frequency probe by a trained clinician with expertise in gynecological imaging. Now, what are the five features? What five features are needed to be identified? Okay, transvaginal ultrasound, a simple cyst is associated with the five feature: round or oval shape, thin or imperceptible wall, posterior caustic enhancement, anechoic fluid, and absence of septation or nodules. Characteristic of the adnexal mass with a simple cyst is important for the management and ultrasound identification of the simple cyst. Established benign process in 95 to 99% postmenopausal women. And ovarian cyst is defined as complex in the presence of these features: complete septation and solid nodule and papillary projection. Okay, because the complete septation shows 8% incidence risk of malignancy, and if there are solid nodules, then it should then there 36 to 39% risk of malignancy. Now coming toward the last paragraph, that how much is sensitive and specific. How much sensitive and specific is TVS? TVS has sensitivity of 89% and specificity of 73% in distinguishing benign and malignant ovarian tumors. Now, how frequent is simple cyst in postmenopausal women? Okay, simple cyst has frequency of 5 to 17%. And it has been shown that an adnexal cyst of 5 cm or smaller in postmenopausal women are rarely malignant. And here in this paragraph, the important thing are that what are the types of complex tumor in postmenopausal women. Postmenopausal ovarian cysts with a solid component include benign ovarian tumors such as some teratoma, cystadenoma, cystadenofibroma, malignant ovarian tumor, primary and metastatic. Now, what is the role of Doppler and three-dimensional ultrasound study? Color fluid Doppler studies are not essential for the routine initial assessment of ovarian tumor, ovarian cyst in postmenopausal women, and spectral and pulse Doppler indices should not be used routinely. Okay, we are aware of the different Doppler indices, which include the resistive index, pulsatility index, peak systolic volume, time average maximum velocity. These are not very helpful in routine to differentiate benign from malignant ovarian cyst, as their use has not been associated with significant improvement in diagnostic accuracy over morphological assessment by ultrasound. Then three-dimensional ultrasound morphological assessment does not appear to improve the diagnosis of complex ovarian cyst, and its routine use is not recommended in the assessment of postmenopausal ovarian cyst. Okay, so there is no specific role of Doppler, there is no specific of three-dimensional ultrasound. Now coming to the other points, what is the role of CT, MRI and other cross-sectional imaging? Okay, the CT, MRI, post-dawn emission tomography scans are not recommended for initial evaluation of ovarian cyst in postmenopausal women. Okay, and CT scan should not be routinely used as a primary imaging tool for initial assessment of ovarian cyst in postmenopausal women because of its low sensitivity. Okay, its limited assessment of ovarian internal morphology, and its used of ionizing radiation. Okay, why it is limited? First of all, its specificity is low. Secondly, internal morphology is not best studied by CT scan, and it uses ionizing radiation. So primary tool, as a primary tool, CT scan should not be used. However, if from the clinical picture, ultrasonographic findings and tumor markers, malignant disease is suspected, a CT scan of the abdominal pelvis should be arranged with onward referral to gynecological oncologist multidisciplinary team. Okay, because the CT scan helps us to check the degree of metastasis. Okay, so it's written in the last line of this page that whenever there is any suspicion, then CT scan may be indicated to stage a suspected primary ovarian cancer, to identify the primary intra-abdominal cancer, identify the primary intra-abdominal cancer like colon, gastric, pancreatic with the suspected ovarian metastasis. Okay, in order to differentiate between the ovarian and the other type of the cancer, okay, because the ovarian tumor which we diagnose might be the result of metastasis. So in order to differentiate between that, it's very important to do the CT scan. The role of CT scan comes at that point. Now coming toward the MRI. Should MRI be done routinely? No, MRI should not be routinely done as a primary imaging tool for the initial assessment of the ovarian cyst in postmenopausal women. MRI should be used as a secondary line imaging modality for characterization of the intermediate ovarian cyst when the ultrasound is inconclusive. Okay, when ultrasound is inconclusive, then MRI has the role. Okay, now what are the limitations? Okay, MRI has got high cost, more restricted availability and patient related restriction. MRI is contraindicated in certain patients like those with the cardiac markers, cochlear implants, and can have reduced acceptance by some patients, for example those with a claustrophobia. And where does its role come? MRI should be considered for the characterization of the intermediate and axial cyst with identification of enhancing vegetations in the cystic mass and the presence of ascites being the best indicators for malignancy, and further characterization by the MRI is of value where an alternative diagnosis to ovarian neoplasm is thought more likely, or if anatomically the ovarian origin of the pelvic cyst is in doubt. Okay, MRI is valuable problem solving tool when ultrasound is inconclusive or limited due to body habitus, and MRI of sonographically indeterminate and axial mass can be used to guide the patient care and reduce the cost of further management. Then post-dawn emission tomography and CT scan. Current data do not support the routine use of post-dawn emission tomography, CT scanning in the initial assessment of postmenopausal ovarian cyst, and data suggests that there is no clear advantage over the transvaginal ultrasonography. Okay, initial assessment and estimation of risk of malignancy. Which RMI should be used? The RMI 1 is most utilized, widely acceptable and validated effective triaging system for women with suspecting ovarian cancer. Okay, RMI 1 Score with the threshold of 200 has sensitivity of 78 and specificity 87% is recommended to predict the likelihood of the ovarian cancer, to plan further management, and some center utilize an equally acceptable threshold of 250 with a low sensitivity of 70% but higher specificity of the 90%. Now, it's written that CT of the abdomen and pelvis should be performed for all postmenopausal women with ovarian cysts who have RMI-1 score greater than or equal to 200 with onward referral to gynecological oncology multidisciplinary team. So here the role of the CT scan comes. If RMI is greater than 200 based on initial assessment, then we have to do the CT scan. Now, when was RMI score first described? It was described in 1990, and modification has been made in order to describe RMI2, RMI3, RMI4, but they are not of clinical benefit, and the RCOG uses the RMI1. Okay, how to calculate RMI? As I have already explained this in the initial chart, that how we calculate the RMI. And how much is sensitivity and specificity of RMI1? RMI1 has sensitivity of 78% and specificity of 87%. Okay, now another important thing is written in this paragraph, this one. Okay, that how much person has a chance of malignancy with different RMI score. It should be appreciated, however, that no currently available tests are perfect, offering 100% specificity and sensitivity. It is also difficult to correlate a particular RMI1 score to another absolute risk of malignancy. However, women could be considered that RMI score of less than 25 has risk of cancer of 3%. If score is between 25 to 250, then the risk is 20%. If score is more than 250, then the risk is 75%. Now coming to the other point, that what are the other scoring system which are available and when should they be used. Other scoring system have been described, which include OVA1 and ROMA. ROMA is risk of malignancy algorithm. Okay, they may require specific assay which may make the routine use impractical. The IOTA classification, which is based on the specific ultrasound expertise, has comparable sensitivity and specificity to RMI and forms an alternative for those experienced in this technique. Okay, the IOTA scoring system. IOTA scoring system is a simple ultrasound rule and logistic regression model. Okay, LR2. Okay, the IOTA group use these rules, the B rule and M rule. Okay, we have to remember these important points, that in B rule includes those with the benign tumors, and M rules are for malignant tumors. So B rule include if it is unilocular cyst and presence of the solid components where the largest solid component is less than 7 mm, and presence of acoustic shadowing and smooth multilocular tumor with the largest diameter of less than 100 mm. Okay, even if it is smooth, then the largest diameter is less than 100 mm and no blood flow. Okay, if we have these features, then it follows the B rule. But if it is irregular solid tumor with the sides at least 4 papillary structure and irregular multilocular solid tumors with the largest diameter of greater than 100 mm and prominent blood flow on the color Doppler, then that follow the rule. Now coming toward the ROMA score. The ROMA score is a quantitative test using CA125 HE4. HE4 is basically, as I have explained previously, that it is released from, it is found in epididymal epithelium. It is a glycoprotein found in epididymal epithelium. And ROMA score uses CA125 and HE4 concentration and the menopausal status to calculate the risk of ovarian cancer. A numerical score is obtained based on an algorithm equation with a cutoff value of 2.27 representing high risk of malignancy. Okay, and ROMA must be interpreted in conjunction with an independent clinical and radiological assessment and not intended to be a screening or standalone diagnostic assay. Then OVA1. OVA1 uses the CA125 transthyretin apoprotein and beta 2 microglobulin and transferrin. Now coming toward the management. How do we do the management of ovarian cysts in postmenopausal women? What are the different management options? Okay, it's written that if RMI score is less than 200, then that case can be managed surgically or by laparoscopic salpingo-oophorectomy after discussion with the patient. Conversely, those cysts that are likely to be malignant are best managed with a further imaging in the form of CT scan and referral to gynecological oncologist. Then it's written that do all the postmenopausal women with ovarian cysts require surgical evaluation? No, it's written that asymptomatic simple unilateral unilocular cysts of less than 5 cm have low risk of malignancy in the presence of the normal CA125. These cysts can be managed conservatively with a repeat evaluation in 4 to 6 months, and it is reasonable to discharge these women from follow-up after 1 year if the cyst remains unchanged or reduces in size with the normal CA125, taking into consideration the woman wishes and the surgical fitness. If a woman is symptomatic, further surgical evaluation is necessary. A woman with suspicion or persistent adnexal mass needs surgical evaluation. Okay, it's written that in addition, a study reported that more than 50% of these simple ovarian cysts may resolve within the 3 months. Okay, so if the tumor size is less than 5 centimeter, it is likely that it resolves in the 50% will resolves in 3 months' time. What are the available surgical options? Women who do not fit the criteria for conservative management should be offered surgical treatment and in the most suitable location and setup by the most suitable surgeon as determined by the RMI. Initial surgical option that have been assessed includes the imaging guided aspiration of the cyst, laparotomy and laparoscopy. Now, what is the role of aspiration of ovarian cyst in postmenopausal women? Okay, aspiration is not recommended for a management of ovarian cyst in postmenopausal women except for the purpose of symptoms control in women with advanced malignancy who are not fit to undergo any surgical intervention. Now, could postmenopausal ovarian cyst be managed by laparoscopically? Yes, if the RMI score is less than 200, risk of malignancy is low, then those are suitable for laparoscopic management. Laparoscopic management should be undertaken by suitable trained surgeon. Laparoscopic management of ovarian cyst in postmenopausal women should comprise of bilateral salpingo-oophorectomy rather than cystectomy. And women undergoing laparoscopic salpingo-oophorectomy should be counseled preoperatively that a full staging laparotomy will be required if evidence of malignancy is revealed, and where a possible surgical specimen should be removed without intraperitoneal spillage in the laparoscopic retrieval bag via umbilical port, and this results in less postoperative pain and a quicker retrieval time than when using a lateral port for the of the same size. And transvaginal extraction of the specimen is also acceptable if surgeon has available expertise. Okay, then when should laparotomy be undertaken? Ovarian cysts that are suspicion of malignancy in postmenopausal women, as indicated by RMI score, are greater or equal to 200. CT finding, clinical assessment or findings at laparoscopy requires full laparotomy and staging procedure. If malignancy is revealed, then during laparoscopy or from subsequent histology is recommended that woman can be referred to cancer center for further assessment. Okay, now something very important at the top of this page, that what to do if the ovarian cancer is discovered during the first surgery. If ovarian cancer is discovered during the first surgery, during the laparoscopic surgery or on histology or subsequent A subsequent full staging procedure is likely to be required. Okay, and secondary surgery should be performed as soon as feasible, and it is important to consider borderline ovarian tumor as histological diagnosis when undertaking any surgery for ovarian masses. And it's written that although up to 20% of the borderline ovarian tumors appears as simple cyst on ultrasonography, the majority of such tumors will have suspicious ultrasonographic findings. And how staging laparoscopy is performed? Staging laparoscopy should ideally perform with a midline in CN by appropriately trained clinician and with a clear documentation. And it should include the laparoscopy with a clear documentation, cytology, ascites or washing, total abdominal hysterectomy, bilateral salpingoophorectomy, and omentectomy, and biopsies from the suspicion area should be taken. And some centers may make the decision about the extent of the surgery on the basis of the frozen section according to the local cancer center protocol, and other may alter the timing of the surgery in relation to the chemotherapy in advanced cases, particularly with the advent of the new adjuvant chemotherapy. The laparoscopy and staging procedure may include the bilateral selective pelvic and para-aortic lymphadenectomy. And where should the postmenopausal woman with ovarian cyst be managed? Okay, the appropriate location of post management should reflect the structure of the cancer care in the UK. And coming to the last points, that who should manage the ovarian cyst postmenopausal woman. Okay, it's written that if RMI is less than 200, then she should be referred to gynecology or the cancer unit. And women at the great risk should be managed in the cancer center by a trained gynecological oncologist unless the multidisciplinary team is not supportive of high probability of ovarian malignancy. So that is all about the this guideline. Thank you so much for your patience.